But thank you very much for the presentation and introduction there today. I'm excited to be here. I love teaching this seminar. I love being here in North Carolina teaching this seminar because we have a very special kind of initiative that we've been doing over the last, it's been probably 10 years. And that's teaching good, solid documentation, coding, and compliance here in North Carolina. And as Parker said, I have been in a number of states. I think I've taught 16 or 17 seminars in the last 4 months, and some of those double up on the weekends. But what that's given me is some exposure to other states and what's going on in other states. The things that they're dealing with in their documentation, coding, modifiers, things like that, are things we dealt with a long time ago here in North Carolina. So again, much thanks to H&S. The NCCA has been an important partner in that, and other folks. But we've got a pretty good thing going here in North Carolina. So for those of you who are from South Carolina that are here as well, as we branch down into that, and with H&S doing things down in there as well, that will just continue to strengthen and increase that knowledge base that you have as well. So with that said, again, I am excited to do this. This is the next level. We're not going to spend a lot of time talking about the basic essentials, although we'll hit some of that. But we're going to be focusing in more on the higher level documentation stuff. Medical necessity, outcome assessments. We're even going to look at some of Dr. Binder's notes, some of Dr. Sharp's notes. That's one of the things that came out of last year's seminar, is to show us what your notes look like, okay? I want to be able to compare some notes that you guys are making with the notes that I'm doing. Some of you are doing a great job. Some of you, I'm glad you're here today, okay? So we'll do that. And also, as you know, I like to take questions back and forth. If you have questions, we want to make sure that we get a microphone to you. Do we have those out and about? Okay. So we get those questions to you, but we get those microphones to you and get that recorded. Your questions will be an important part of this presentation. So the last thing you want to do is sit here and listen to me for the next 10 hours. I mean 6 hours, okay? So we'll do that. All right, so let's go ahead and get started. And let's talk about the responsibility. You know, one of the other great things in North Carolina is the president of the American Chiropractic Association is one of our very own colleagues, Dr. Tony Ham. And in his inaugural address, he said, "There has never been a time in the history of our profession with a greater opportunity to deliver conservative health care. The overriding question is, are we prepared to embrace the opportunities? Can we create an environment that promotes greater penetration into healthcare marketplace? And will we be able to create an environment that allows us to practice to the full complement of our training and competencies? Can we create an environment also that reimburses us at a level of all other physician-level providers?" Now, some of you, that's the only sentence you heard of about reimbursement. But the important thing with this is spending your time learning this as part of this process. Because I can guarantee you, if we don't improve things as a profession, this is never going to happen, okay? Because that standard is, it's not an anti-chiropractic thing, it's the cost of doing business. It's what you need to do to be able to participate in this market. And unfortunately, we had just that, you saw that again, an updated report from CMS and the OIG about chiropractors not being able to have quality documentation and how that's affecting reimbursement. And what's going to happen with Medicare is they're going to set standards. That's another thing we're working on. There will be standards that will be set. Some of you may need to have your Medicare visits pre-approved because your documentation doesn't rise to the standards of the rest of the profession. So nobody in this room is going to have that problem or listening to this video. So let's go ahead and jump into it and get on track. So H&S has a mission statement, and it's to make healthcare more accessible, more effective, and more affordable. Sounds good, doesn't it? So consistent with H&S's mission statement, The objective of this program is to help us improve the quality of care and treatment outcomes through the use of best practices and superior clinical record keeping. So again, we've talked some of these slides you've seen before, but there are documentation authorities. So the North Carolina Board of Chiropractic Examiners, our Board of Examiners, again, in any state, it would be in South Carolina as well, that really defines the standards of documentation here. And they have the North Carolina Practice Guidelines, which you have a copy of that. Hey, docs, if you have not read through that, I know it's riveting information, right? To sit down and listen or read that stuff on an afternoon or an evening. But take the time to kind of go through there. There's some very specific information, and I would also encourage, I've said this before, but for those of you that have an EHR system that can customize that, there's good information that you can copy and paste from that, kind of reword it so it fits into your language, but that's a great thing to use regulatory board information from their practice guidelines to put into your EHR. That really beefs up your notes. The American Chiropractic Association obviously is very important. The ACA gets its information, its directives from CMS. And CMS kind of sets the real national standards for documentation. And Parker mentioned that we're working on a new plan. We're rewriting the documentation manual. And it's kind of an interesting thing. One of the great things about the new documentation manual that's being written is it's got examples. So if you've got a certain code question or a particular modifier question, you can go into that documentation manual, and we've given you a kind of a case study for that. So it really makes it a very viable, very living document. And that also will be an electronic document as well, so you'll be able to use that as well. Optimum has its kind of black box, its standards of care, so certain carriers can have standards of care, and then H&S has the clinical quality record standards, which are based on best practices. Okay? And again, if you're using the guidelines for documentation that we talk about today, that will take care of you, whether it's Medicare, whether it's Blue Cross Blue Shield, whether it's a cash patient. It really is a high standard of documentation. So this is what you want to focus on. And unless otherwise indicated in this presentation, the clinical record-keeping standards referenced in this program are H&S standards and should not be confused with standards or guides issued by licensing boards or the ACA. Yes?
The best practices, how's that defined? By who?
Well, that's essentially best practices are defined. That's a good question. They're defined by different people. It would be through CMS. It would be through the educational institutions, and then also just kind of practice standards that we have. Would you add anything into that?
Our H&S best practices, the clinical record standards that Dr. Sharp's going to refer to and throughout here, are the standards. The best practices were developed by the H&S Professional Affairs Advisory Boards. Those are boards across North and South Carolina made up of participating providers. And they are based on, as Dr. Sharp said, industry documentation standards. Our attempt was to make sure that if you adhere to these standards, as Kevin said, your documentation would satisfy Medicare requirements, Aetna, United, or anyone else's. That helps.
That's great. Thank you. All right, so again, they've developed these best practice standards, kind of answers the question for clinical record keeping, which promote the delivery of safe, timely, effective health care. And these standards are included in the handouts that you have, and these are also included in the H&S Protection Plan and available on the H&S website under Clinical Resource. Lots of great opportunities. Staff, how many staff do we have today? Oh, this is the creme de la creme here. Thank you for being here today. I know there's nothing more than you'd rather be than listening to me talk about documentation. So thank you for being here. But part of that, making sure you get on the H&S website. I'm going to refer to that a few times today. There are forms, there are other things that we'll talk about, but make sure that you download these documents so you have them in the office. Staff, I don't expect you to read that document, but there are a lot of things on that website that are designed for you. So make sure you take advantage of that and take a look at that. So the clinical records quality standards were developed by the H&S Quality Management and Improvement Committee with guidance from H&S network physicians serving on the H&S Professional Affairs Advisory Boards. These are consistent with industry standards, federal and state laws, and the policies of their contracted payers as well. And they were designed to help ensure your documentation meets the high expectation standards for all payers, including Medicare, as we've mentioned. And H&S's best practices for record keeping establish H&S's performance expectations for contracted healthcare providers as well. Okay, so we've got to talk a little bit about the basic essentials. I want to make sure you're doing things right. Every single time I teach this class, I go back and my records become better. I pick something up, I'm reminded of something that I have kind of slacked off on, okay? I'm just being honest. And I improve that when I go back. So by the end of the day, you should have a list of things that you want to put down, that you want to take back and enhance the records that you're delivering at this point today. So as we go through some of these basic essentials, these are very simple, just to highlight or outline or circle or whatever you do. But these are a must-have in your notes. So excellent clinical care should be evidenced through excellent documentation in the clinical record. And that documentation, the clinical record, is essential for sound clinical decision-making, which improves quality of care and treatment outcomes and is paramount to appropriate continuity of care. So lack of appropriate documentation can lead to negative treatment outcomes and potential quality of care and patient issues. And again, part of us, chiropractors, is just give me a list of things I've got to do. As soon as I check them off, then I'm done. You know, I'm going to be able to go out of my office and do the things I want to do. But really, quality records documentation is about providing good care for your patients. Okay? I think high-tech has helped me become a better provider. I think ICD-10 has definitely made me a better provider, and certainly spending the time talking about documentation has certainly made me a better provider. I look at my CPR in a different way at the end of the month. When I see that, I want to see what are my trends in my practice. We now talk about that as a staff and staff meetings. It's not to just check off good documentation or sign off all my notes at the end of the day. I want to make sure we're actually doing a better job for our patients, and it starts here in your documentation. So speaking of EHRs, the use of electronic health record systems, EHRs, is highly recommended. Again, it's just hard to keep up with all the information. And if the electronic records are utilized, there must be appropriate backup and recovery procedures in place. Recovery procedures should be tested at least annually to assure recovery is possible within a reasonable period of time. I had a situation a couple years ago where we lost some records. We were able to get those back over time, but make sure that regardless of which EHR, whether it's a server-based or a web-based EHR, that there is a backup system, that you understand that. Are you backing up those servers that you have? If you haven't had a server crash, then yours is coming. So it's just technology, and it breaks down over time. So make sure that you are sustaining those notes. The one thing that I would say about EHRs and note keeping your records backed up is, again, we have high standards for a number of years to keep those records, and electronically it takes no space. Many of you have been in my office. I have a little less than 1,200 square feet. We have no filing cabinets in the office. I have no records in some storage unit or in the back of my garage. So electronically, it's very efficient to keep those records in an electronic format. So I would encourage you with that. And with respect to retention, complete patient health care records, including billing and payment information, even EOBs, shall be maintained for a minimum of 10 years from the last date of service, or if the patient is a minor, for 10 years after the minor reaches age 19. Once the patient reaches 19 and still under care, the provider should retain the patient health care records for 10 years from the last date of service. So you could easily have records for 30, 40 years on a given patient that's been with you for a while. And yeah, I've only been in practice. Last time I gave the seminar, Parker introduced me as having been in practice for 72 years. So this is what good chiropractic care does for you. All right, so a note about the basics. The basics of clinical record documentation were really covered in a lot of detail in last year and the previous year. So we're going to, again, those are included in the H&S Clinical Records Quality Standards, so we're going to jump forward and look at documentation practices that will help us improve treatment outcomes and quality of care. So again, higher level stuff, okay? So building the foundation for clinically supportive documentation. Let's talk about the initial visit. We'll go through this quickly. Again, if you have questions, feel free to ask me, but this is kind of some of the basics we need to cover. So we've got to have all that basic demographic information, dates, family history, social history, all of those things. Now, the one thing I would also say is when you're collecting this information, let's spend some time and look at it, okay? So there are things that you'll find relative to the patient. What type of work they do, obviously, what kind of sports they do. I have a patient in my practice who I knew was physically active, and I knew he did a lot of mountain biking. But what I didn't know until I read into his note, he actually does extreme mountain biking. So in the summer, they'll get on top of a ski hill, like one of the Sugar Mountain they have a track here in Sugar Mountain in North Carolina, and they literally go full steam ahead down a ski hill on a mountain bike. Okay, and he's fallen, he's got a helmet, so he's had multiple pretty significant traumas. So obviously that changes what we're doing in our practice. So make sure you're looking at those details. Current and significant past medications, all that information, again, if you've got an EHR, you can really drag that into your note. That's very helpful. Allergies, medication allergies, intolerances, adverse reactions, and any contraindications to potential treatments that should be clearly noted, okay? Any health risk factors that have been identified. Let me go back. I had a patient in about a month ago and did the history. He had low back pain. This is a gentleman, late 50s, and it wasn't till I looked a little closer at his medications, I said, I don't know what this medication is. Come to find out, he had prostate cancer, was being treated for prostate cancer, was coming into me for low back pain, and obviously, had we not seen that information, it may or may not have affected our treatment, but obviously pretty vital for that particular patient. Fortunately, it was more mechanical in nature. It did not relate to his cancer, and that was very helpful. But that's where you get that information. And he was remiss in telling me that, right? The chiropractor doesn't need to know about my prostate cancer, so you need to keep looking a little closer. And any health risk factors that have been identified, such as that. You also have to have the chief complaint. Make sure you're getting all the complaints. Now, again, it's very easy to get caught in with a primary complaint. Somebody comes in, they've got low back pain and leg pain. And then, oh, by the way, I've got a right elbow problem too, but the primary complaint is down in that low back and that leg. Make sure you get all that information, but make sure you're getting that elbow assessment in there as well. So when you go to do your documentation, but let alone your coding and getting reimbursed, that information is there. Did you have a question? Yeah.
The doctors. Oftentimes there'll be a statement that the patient's past medical history is indicated on the entrance form and is available for review. Is that acceptable?
Well, if it's part of the if it's part of the record, but they should be if you're getting those records from another doctor, they should be sending you that form. You know, that's invaluable information that you need to have. So again, my point is just that needs to be integrated. It just doesn't need to lay in a file. It needs to be integrated into the note. And certainly any observations that are related to past history should be in the note as well. Okay, good question. All right, good. So chief complaints are important. Onset, duration, frequency, all that stuff, radiation of symptoms. This is the easy stuff, right? But I can tell you it's not done routinely in some offices. So make sure you're getting that done. Aggravating or relieving factors, causation, accident, injury, or other etiology, and whether diagnostic tests or patient histories revealed any contraindications warranting x-rays or prior treatment. So all that stuff's important. Evidence-informed consent, and we'll talk a little bit more about informed consent. So you need to make sure all of that is in your record, okay? So let's talk about the initial exam. The patient's healthcare record should include all clinical examination findings, both subjective and objective, as well as the results of all tests performed. You know, Doc, this is kind of what you're inferring is, you know, you've got your note, some of you have the note, and then you have a file with all the other pertinent information, and they don't really coexist together. You need to have that together. And again, I hate to bring this up again, but this is where EHR is so good, because you live in this. So if you have an MRI report, you're working with the patient, you're 6 weeks into the care, and there's just something you want to look at a little deeper, it's great just to be able to immediately pull up that MRI report while you're with the patient and not have to go out and have a file pulled and that. It's all about the efficiencies of technology in getting that information. Why? To make good, sound clinical judgments for the patient. So that's important. Medical necessity requires documented, objective clinical findings. We're going to talk about this ad nauseum today, so, but we're going to make sure it's clear. Vitals must be taken during the initial examination, results documented in the healthcare record as well. And the clinical record should include written evidence of examination for presenting symptoms, including examination of area involved in the chief complaint. Okay? Again, complaint or complaints. Make sure if you're billing for a service that you've done the examination, right? Some of you will quickly do an examination on, again, an elbow, for example, or a shoulder, and not put those results in your records. Make sure you're getting that in there. You've indicated there's a problem with the shoulder. You definitely need to do the examination of that area, put all the results, if you take films or whatever you're going to do, and then, again, that becomes part of your treatment plan, and we'll talk about that a little bit more. But detail, as I like to say in my office, sweat the details, all right? Sweat the details in this. And the examination should include a consultation to ascertain the history and appropriate orthopedic, neurological, and chiropractic test, and that's necessary to establish the extent and severity of the injury or condition and to allow the physician to establish objective, measurable, and reasonable treatment goals. And the clinical record must also include significant, sufficient documentation to substantiate the specific level of E&M code reported. So, you don't determine the E&M code based on if it's PI, you do a 99203, and if it's Blue Cross Blue Shield, you do a 202 or anything like that. You make sure that you're billing the appropriate E&M exam based on what's necessary for the patient. And if you don't know those standards to determine which level of coding, those are in your booklet today, aren't there? Yeah, so all that stuff is in your booklet. And that may be a takeaway today as you go back and look at that. Frankly, some of you overbill, okay, overcode for that, and I bet you there's a number of you that undercode for that. So make sure you're coding and billing appropriately so to cover the amount of work that you're doing. You want to make sure that's getting done. So that would be something I would look at as well. All right, outcome assessments. How many of you are doing outcome assessments on a regular basis? Okay, a few of you. this is what I want on the top of your list. And we're going to look at outcome assessments. We're going to see how important that is. I can tell you is the most important thing you can do in your notes on Monday to improve the quality is implementing or using outcome assessment forms in your practice. It's free. I like free. How about you? You can download a number of outcome assessment forms excuse me, on the website, the H&S website. There are a lot of them available. Many of you have them in your EHRs. It's integrated, but those are very important. So the other thing is H&S requires them. So H&S requires the use of outcome assessment tools on the initial exam to establish a baseline and on all subsequent exams to determine the effectiveness of treatment provided and to measure the patient's progress towards the treatment goals. Okay? Everything's based on that. So do you need to see a patient for 20 visits? A Blue Cross Blue Shield a patient? No problem. As long as you have objective measurements along the way to see progress or lack of progress with the patient's reasonable, measurable treatment goals. Outcome assessments are part of that. Do they only need to be seen 6 visits? Same thing. If you need to see them 15 visits, it doesn't matter the number of visits as long as you can demonstrate the medical necessity and the need for further care. And outcome assessment tools are very important, and we'll talk more about that later. Subluxations. Clinical exam findings must include specific segments and location of subluxations. And there are 2 ways in which the level of subluxation may be specified. Number 1, the exact bone may be listed, or the area may be listed if it implies, for instance, like lumbosacral, occipital atlantal, those things, the access. Either one of those is sufficient, but it needs to be specified in your note. And to report CMT on H&S for contracted payers, or to CMS for that matter, subluxations must be demonstrated by one of 2 methods, X-ray or physical exam. So, X-ray, the X-ray reporting indicating subluxation and signed by the physician included in the healthcare record will serve as demonstration of the subluxation. So are you putting those, great to take those low back films, but are you putting the information and pointing out the subluxations from those films in your record? That's very important. And then on the physical exam, if you do not demonstrate subluxation by X-ray, your clinical record must clearly substantiate this per below. To demonstrate a subluxation based on physical exam, 2 of the 4 criteria below are required, one of which must be asymmetry, misalignment, or range of motion abnormality. So, number 1, pain or tenderness, evaluated in terms of location, quality, and intensity. Very important. Asymmetry, misalignment, identified on a sectional or segmental level. And range of motion abnormalities would be helpful. Again, changes in active, passive, or accessory joint movements resulting in an increase or decrease in sectional or segmental mobility. Very important. And tissue changes in the characteristic of contiguous or associated soft tissues, including skin, fascia, muscle, and ligament. So, in that case, what is it? Again, either by X-ray or if it's physical exam by 2 of those 4, one of which must be asymmetry. So in my records, I'm an old Gonstead guy, so I use listings. So it will be an L5 PRS or a C7 PRIT. Anything like that is going to be sufficient. It needs to be, and you can spell that on a little bit more detail if you're more functionally minded with respect to that, but specific levels should be in your notes. Okay? Any questions on that? All right. You guys are so smart. We're going to run through this basic stuff and get into the other stuff here shortly. The bottom line on your CPT coding is for services provided and billed to H&S contracted payers, clinical examination findings must objectively substantiate the medical necessity of the services provided and must be consistent with the patient's chief complaint, diagnoses, and treatment plan. So there's kind of a thread that goes through this whole process. And this may be what you want to look at in your notes. If I were to walk into your office and randomly pull out a note for one of your new patients in the last week, would I understand the process and where you're headed with this patient? What was the problem? What were the chief complaints? What were the exam findings? Okay? What was the treatment today? What's the treatment going to be down the road? What are you trying to do? Okay? Well, getting rid of pain may be one of them, but functionally, ADLs, what are you doing for that patient to improve the quality of their life, to meet those goals? So that kind of thread, that stream of consciousness throughout their treatment plan should all be outlined on that one date of service. Again, you'll see that. I've got that, and you'll see how I do it, and Dr. Binder does it in our notes. But that first initial exam is vitally important, because if you don't do a good job on the first day, it'll never come together for the rest of your treatment. So make sure that's the case. But importantly, starting with that chief complaint and that exam, make sure you're detailing things out. Again, I realize it's so much easier to focus in on the primary complaint and not get the information for the accessory complaints. But make sure you're getting that all into your notes, and you're getting that stream, that thread throughout for your initial exam form for all of those complaints. Okay? So H&S best practices assessment and diagnosis. The assessment should include any obstacles to recovery and strategies to overcome if applicable. And the assessment should also include diagnoses and prognosis. Treatment goals may be included in the assessment if they are not included in the treatment plan. Okay? So what would be some of the obstacles to recovery? Okay? I think of a patient I had this week, presents to my office with low back pain, and he is rolled in a wheelchair. Okay? I don't know about you, but I think that's a significant obstacle. And this is temporary. This isn't a permanent position to be in the wheelchair. It's temporary because of his low back condition. He cannot bear weight. He's non-ambulatory. So that's kind of a unique thing. So do I put that in there? Absolutely. Absolutely. So we want to put those things. There are other things. Patients that have had knee surgery in your office, or not in your office, maybe not. Maybe you are doing that on the weekends to pick up some extra money doing knee surgery, but I would recommend against that, okay? But let's say you're dealing with a unstable SI joint, and it's because somebody just had a knee replacement, or they've had an ACL tear that's been fixed, and so that's affecting your ability to completely resolve that low back injury. That seems reasonable, doesn't it? But the only reason I would know that if I were looking at your notes is if you put it in your notes. So make sure you're putting those things in your notes. It's very important. Yeah, Doc?
If we do put those things in our notes, obviously they need to be there, but are they required in any way, oh, I'm sorry, I'm pretty loud. Are they required in any way to be in your actual coding? We don't really need
diagnoses?
Well, no, your coding, not necessarily the diagnosis, but if we code for that, if I have a patient, do I need a complicating factor of that? So if I do low back pain, do I need a complicating factor of, say, a ACL repair or a post-surgical something?
Yeah, well, yeah, absolutely. Yeah, you want to have all that information. Again, that's part of, again, I call it the blessing of ICD-10 in their diagnoses, of being able to put all those things in there if it's directly related to what you're doing in your practice. So it gives more value, more latitude to what you're doing. So yeah, I would do that. Okay? You know, we were talking about ICD-10. I'll just talk for a minute about that. It's gone pretty smoothly, hasn't it? Okay? It's really not a complicated thing. It's stuff like this that you're probably not doing now. Also the place of occurrence and external cause codes you're probably not doing yet. So as I like to say, as the noose tightens a little bit on this, you'll have to put a little bit more work into it, add a little bit more value into what you're doing, your ICD-10 coding. But again, it's going to add so much more enlightenment to your notes with respect to looking at them from the carrier's perspective. Good. All right. That was the carriers out there doing that. All right, any other questions on that? Well, let's keep going past ICD. Oh, no, okay.